All right, welcome to week 4. We are going to go over antibiotics this week, basically. So 2 PowerPoints that we'll head through. The first we're going to start with is called Antimicrobial Agent Mechanisms of Action and Resistance. So in other words, what are different antibiotics? How do they work? That's what we're going to basically discuss in this PowerPoint. So let me just put this kind of in slideshow form. There we go. All right, so there's the objectives that you should take away out of this PowerPoint specifically. I think the biggest thing is going to be just remembering what categories all the antibiotics fit into, so how do they work or target the bacteria, that kind of thing, to inhibit or kill it. So as it says here, an antimicrobial agent, what we all call antibiotics, but there's also antivirals, antifungals. They basically work to inhibit or kill that infecting microbe. It must be usually the agent's in an active form to do that. They must have sufficient concentration, so there's always a dosage that they prescribe to you so that they really help eliminate that microbe that they're targeting. And then there will be a direct interaction that will take place between the antibiotic and between the bacteria. Some terms, you might be already familiar with these, but keep these in mind. Bacteriostatic is an antimicrobe agent that inhibits bacterial growth but does not necessarily kill the organism. Whereas bactericidal, cidal for kill, it will actually kill the target organism. So again, we categorize all of our antibiotics according to their mode of action, meaning how do they act upon that bacteria so that they can destroy, inhibit, kill it, whatever method they're looking for. So the most common modes of actions are going to include targeting the cell wall, cell membrane, protein synthesis, and DNA or RNA synthesis. So that's going to be the majority of our antibiotics that we're going to discuss. So we're going to start with those that inhibit the cell wall synthesis. We have 2 very large groups of antibiotics here that do this. Glycopeptides is one group that will target the cell wall synthesis. Within this group, there's many different names of antibiotics, and you should know a few of those names. Vancomycin is probably the most common one that exists within glycopeptides, and it's one that you should definitely be aware of. So primarily, again, vancomycin likes to target gram-positive bacteria, and so that's kind of what it goes for. Now, not all glycopeptides, I want to say all of them will target gram-positives more than gram-negatives. So because your antibiotics can either be gram-positive targeting, gram-neg targeting, or they can be considered broad spectrum. And if they're broad spectrum, that means they target both gram-positive and gram-neg bacteria. Whereas I think glycopeptides, because they're targeting the cell wall synthesis, these ones are specifically looking at gram-positive bacteria is the way that they've been made. Beta-lactams are the other really big group of cell wall synthesis inhibitors. These are all your penicillins, so very common antibiotics that we get prescribed a lot, penicillin, amoxicillin, all of those. They're the biggest group that we have of antibiotics, and they're named beta-lactam because they contain a beta-lactam ring. Now, there has been bacteria that have come to learn how to resist these beta-lactam antibiotics, and that's because they make an enzyme called beta-lactamase. So these bacteria have started to make this enzyme, beta-lactamase, and that enzyme will basically bind onto the beta-lactam drug and hydrolyze that drug. So basically it puts it out of order. It makes it so that it doesn't work. It targets that beta-lactam ring within the beta-lactam antibiotic. So you will hear of bacteria that are easily resistant to penicillin, amoxicillin, all those, and that's because usually they have these beta-lactamase enzymes that they have formed. They've learned from it. All right, it inhibits cell membrane. These are different than cell wall cell function. Our peptides and your polymyxin. A common example of polymyxin would be colistin, and these ones are going to target gram-negatives. The polymyxins will target gram-negatives. If I don't say what it specifically targets, by the way, just assume it's a broad spectrum. All right, those that inhibit protein synthesis, there's a ton of them. Aminoglycosides is another big group here. Gentamicin is probably one of the most common examples that exist in that group. Macrolides, ketolides, oxazolidinones, that's a hard word, chloramphenicol, tetracycline, and glycoglycines are all great categories that fit into inhibiting protein synthesis. Within each one of those are going to be different examples of antibiotics. You can take a look to see if you recognize any of the names. All right, inhibiting DNA is going to be fluoroquinolones and metronidazole. Inhibiting RNA synthesis is rifampin. The beauty of that is the R's go together, rifampin with inhibiting RNA. That's the only one that we will discuss that inhibits RNA synthesis. And then things that inhibit other processes, sulfonamides and trimethoprim will both inhibit folic acid pathway, and nitrofurantoin, and it does also inhibit another metabolic process, and this one's specifically used to treat UTIs a lot of times. Okay, so mechanisms of antibiotic resistance. As we've seen, there is going to be bacteria that are resistant to antibiotics. We talked about the formation of that enzyme beta-lactamase. There's other ways that they become resistant, so this is just kind of different ways that happens. Biologic resistance is just going to refer to changes that result in that organism just being less susceptible to the antibiotic, whereas a clinical resistance is when the antibiotic susceptibility has been lost because the drug is just not effective. So biologic refers to the bacteria becoming resistant. Clinical refers more to the drug just not being effective anymore. There's also environmentally mediated resistance. So this is anything that can change in the environment around you or within you, such as pH, your cation concentrations, different anaerobic atmosphere. All those kind of things will kind of result in a change or a resistance to that microbe, to the drug. So it's just due to something changing within or around you. And then microorganism-mediated resistance. So there's two categories here, intrinsic and acquired. Intrinsic resistance will result from a normal genetic, structural, physiological state. Acquired resistance is resulting from altered cell physiology and structure. So basically kind of like a mutation, if you will here, more unpredictable. All right, so the biggest thing to take away from that chapter, again, is knowing your categories of antibiotics, what their mode of action is, and also remembering any ones that we mentioned, if they specifically target gram-negs or gram-pos, remembering that. And then just take a look at a couple of the example ones that fit into each category so you know those names. Unfortunately, antibiotics is a lot of memorization. Okay. So the second PowerPoint specifically deals with how do we perform susceptibility testing within the lab. So, oh, just a second, I clicked on something wrong here. There we go. All right. So susceptibility testing is our test that we run so we can determine and show the doctor, okay, this bacteria was susceptible to these antibiotics or resistant to these antibiotics. So with every time that we identify an organism, so say we get a wound culture, a urine culture, whatever it might be, and we identify that bacteria, we are also giving that doctor the bacterial identification and the susceptibility results, meaning we're going to tell him or her what that bacteria has been resistant or susceptible to, so they know, have they prescribed the right thing? Because usually the patient is on antibiotics already by this point, but sometimes they're put on an antibiotic and then it'll come back, oh, but that bacteria is resistant to it. So then they know, okay, I need to switch them off of it and put them on something different. So it's a good guideline. It shows them exactly what works against it and what doesn't work. So that's susceptibility testing. You can also call it sensitivity testing. So whatever way you want to word it, sensitivity or susceptibility, same thing. All right, so we want to make sure that whenever we do this susceptibility testing, we have a really good standardized process. The reasons, basically the reason is to avoid contamination and false results. But the three purposes are that you're going to really optimize the bacterial growth conditions, really make sure that if the bacteria has a chance to really grow if it needs to. So that way, if it didn't grow, we knew it was because the antibiotic inhibited it, not because the temperature of the environment wasn't right. So we really want to make sure we're putting in the right ideal environment so that if it's going to grow, it's allowed to. But if it is inhibited, it's because the antibiotic killed it off, not because it didn't like the growth, the area it was in. So we also, same thing then, we want to optimize conditions for maintaining that antibiotic integrity and activity, making sure the antibiotic has a chance to work, and then having these results be reproducible. So if I were to do them versus Joe next to me versus Sharon, whoever it might be, they all are the same results. There are guidelines that are published by CLSI. If you don't know who CLSI is, it is the Clinical and Laboratory Standards Institute. They basically publish tons of voluntary guidelines. No, I say voluntary because these are by no means something that you have to follow or use, but they are really good guidelines, and they have done their research. They know what really is something that should be followed, so something to take into account. They've published guidelines for every area. Phlebotomy is a big one with them, what they publish. So they just always give out good guidelines on what to appropriately do, and that would involve standardization. All right, so different components that will be involved in making sure that the testing is standardized is how much bacteria do you put into the test, like the inoculum size is what we call it. So in my last lab, the way that we made our susceptibility test, now this varies every lab depending on what setup you have, but in my last one, we would always take 3 to 4 colonies, isolated individual colonies only, like that was the rule. So you knew that that was the amount of colonies you're allowed to pick out to put into the liquid, and so it would make the exact same, usually around the same concentration, so it was pretty much the same inoculum size. So you just follow the exact same rules wherever you are. Your growth medium, typically we're using what we call Mueller-Hinton agar. There's a specific agar called Mueller-Hinton, works really well if you're using an agar plate. You're also making sure that you're incubating the same temp, the same atmosphere, the same length of time, and that you're using this exact same antibiotic concentrations. So usually you'll order a panel in from a manufacturer, and on that panel is all the antibiotics already laid out with them already concentrated, you know, in different amounts of concentrations. Because not only are we deciding, oh, the antibiotic's resistant or susceptible, but also what dosage to give it. Is it susceptible at the minimum dose, or is it resistant up to a certain dose, and then after that it's susceptible? So that goes into the concentration or dosage of that antibiotic. Typically, you can order from a manufacturer. It's already set up for you. So there are 3 testing methods that you can use to detect susceptibility. The biggest main one now is in an analyzer, and you set up a panel. You incubate that panel, let it grow out for a day, and then you throw it into an analyzer for it to read. And so it's directly measuring the activity of 1 or more antimicrobic agents against that bacteria. So usually there's quite a few antibiotics on there that it's reading for. It's looking to see, did the bacteria grow in the presence of that antibiotic? If the bacteria grew in the presence of the antibiotic, the bacteria is resistant, meaning antibiotic did nothing for it. It didn't stop it at all. If there's no growth with the antibiotic, that means the bacteria is susceptible. In other words, that antibiotic works on inhibiting or killing that bacteria, so that's a good one to give to the patient because it will kill off that bacteria. So resistant means the bacteria is not phased at all by the antibiotic. It will grow in the presence of it. Susceptible means the bacteria is susceptible to antibiotic. It will work on it. It cannot grow in the presence of it. All right. So these just next couple ones give you examples of how they perform this testing activity. So to directly measure the antimicrobe activity, again, they can use commercial susceptibility testing. That's most common with analyzers. There is ways that you can streak it across the Mueller-Hinton agar and put little discs of antibiotics on the agar. And that's something I think that you're going to do in labs, so you guys will get to see that. And then you read a zone of inhibition. And so your lab instructor will really help you with that. So this just talks through an inoculum preparation, how to select colonies of the same morphology and size. This says 4 to 5 colonies. It just depends on what your lab tells you how many colonies to collect. To make a pure culture, you want isolated colonies so that you know you're only picking up that colony type. You don't want to go up into a crowded area because it's too risky to get contamination. And then again, what I call the antimicrobial panel, that's what we order in from a manufacturer, already has all your antibiotics on it. And again, that CLSI has a whole table within their guidelines of potential antimicrobial agents that should be on that panel that you're reading. So these are different panels that you can order in. These are large, frequently seen bacteria groups. So we're going to learn all about all these different bacteria groups as we go through Micro 1 and Micro 2. Don't worry about this slide at all. It's just to say, of course, whatever bacteria you find, we can have antibiotic testing for it. All right, there's a term here that's in bold called MIC, which is minimal inhibitory concentration. So like I said before, when you get these panels in, they have the antibiotics on it. They will also have different concentrations or dosages of that antibiotic on it. Sometimes the bacteria can be inhibited by all dosages. Sometimes the bacteria can grow the lowest dosages and then be inhibited. So what the minimal inhibitory concentration is, what is the lowest level or lowest dosage that completely stopped the bacteria from growing, that completely inhibited that bacterial growth? And that would be what we call the MIC. So the MIC is usually the doctor will use that lowest amount that really stops the bacterial growth, just because you don't want to use a super strong one. You're trying to minimize the amount you're giving anyway. We don't want to expose the bacteria. Bacteria have become resistant because we've used antibiotics too much sometimes for things that don't need it always. So we just want to use the lowest dose. We don't need to necessarily go right to the strongest dose always. The lowest one that works on that bacteria is the one that can be given, but that's commonly called the MIC. And again, it will be termed susceptible, intermediate, or resistant, and then the doctor will read that. So they'll go down and be like, oh, penicillin was resistant, cephalosporin was resistant, you know, gentamicin susceptible. So that's kind of what they'll sit there and read. Intermediate means it's not quite susceptible, but it's not resistant fully yet. Probably not the best to use an intermediate because it's not going to fully function. All right. These are a couple terms that you can skip. I'm not going to worry about those right now. There's other testing methods that involve an agar dilution, a disc diffusion. That's where you put the little discs of antibiotics on the agar. So you guys are going to do that in lab, so you'll see that. Here's the names of different analyzers. The Vitek is a very common one, along with Microscan. I personally worked on Microscan myself, but a lot of labs do have Vitek as well. Phoenix, I don't know if they have those anymore. I've never seen a lab with Phoenix anymore system. They were something that was up and coming when I was in the labs, but I haven't seen one in a long time. They might still be out there, they might not. I don't know. All right. And some other antibiotic terms. Synergy just means the antibiotic activity is greatest when it's used alone. Antagonism, I'm sorry, I knew I said that wrong as soon as I said that, so I paused. Synergy is when a combination of antibiotics works better together than when they do on their own. So that's why sometimes you get those combo antibiotics given to you. It's just in combination, they'll work even more efficiently than if you were to just get the one on itself. That's synergy. Antagonism basically means that the drug works best on its own. So putting them together wouldn't be as effective as just giving the one. All right, that's it. I feel like the susceptibility testing is even more understandable when you guys get to play in the lab, and especially when you see the discs used with the zone of inhibition. So just be patient, you'll get to see them, and I feel like you'll understand it so much better then. But just make sure you take away some of those key terms that we did discuss in here. If you guys need anything, as always, please feel free to reach out. Otherwise, have a fabulous week. Thank you.